people need to understand biomarkers because they may be very dry and difficult for patients to get to grips with. But actually, if you're going to do targeted therapy to a specific molecular lesion, you need a biomarker to show it's in the tumor. So we know that proteasome inhibitors can improve the outcome of 414 myelomas. So you can use FISH to find the 414. You can expose them to more proteasome inhibitions. For the 1114s, we know they're the ones that will respond to venetoclax, and again you have a biomarker in the iFISH which finds it, and you know that only those ones will respond to the venetoclax. So there are other markers like RAS-MAP kinase mutations, and those would be amenable to therapy, but you need a mutation test to find them because you'll only respond if you have the mutation. And so I think there's a way forward where we can find treatments for the RAS mutated myelomas and give them in combinations. And as they occur as defining events of myeloma occur early in smoldering myeloma, they may be effective in smoldering myeloma to reduce the size of the clone, but certainly giving in combination later in the disease, they may be appropriate as well. So there's a lot of way we can go about personalizing therapy, but for a lot of them you need a biomarker, and so biomarkers of a lesion, but we also need biomarkers of response, because really MRD and monitoring MRD is a biomarker. And if somebody doesn't achieve a deep response with one type of agent, clearly you can switch to another agent with a different mechanism of action and get them to the deepest response. So all of these fit into personalization of therapy. And I think that is one of the major ways forward to improving patient outcomes.